Welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals who are dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Well, welcome to the Veterinary Cancer Pioneers Podcast. I'm your host, Dr. Rachel Venable. I am so excited today to introduce our guest, Dr. Pamela Jones. Dr. Jones has been involved with multiple areas in the veterinary field. She's actually an Arizona native, which is pretty rare. As someone who lives here, I can say there's not many natives, but she grew up in Tucson, went to college here, then went to veterinary school at Colorado State. And then went on to get boarded in medical oncology and then later radiation oncology. And she also, before vet school, worked as a technician, which I do want to talk about that a little bit as we go through, because I think it can be quite a valuable experience. And you were in clinical practice for a long time and have then moved on into industry and are now actually the Chief Veterinary Officer at QBiotics and has been heavily involved with Stelfonta, which we'll also talk about that. It's a pretty exciting and very different type of therapeutic that's out there. So, Dr. Jones, I want to thank you so much for being on our show today.
Thank you. It's a pleasure to be here, and I'm excited to share whatever I can with any listeners, just to whether that means to help them or just give them some insight into some different avenue.
You certainly have a lot to offer. I think it's interesting how your career has evolved over time. I think that's interesting for people because sometimes we get stuck thinking all we can do is clinics. So I think it's interesting to see how you've evolved. And then, of course, just hearing about Stelfonta, it's such a different product. And I know I always get a lot of questions about it. So I'm sure you do too. But going back to the technician, when I was applying for vet school, I did mostly volunteer. But how do you feel, working as a technician? How do you think that even shaped your career or, you as a veterinarian?
Yeah, it's interesting because the experience really did provide so many benefits to my career. And not only, I knew I wanted to be a vet. I was the typical kid at, age 4 said veterinarian, veterinarian, what do you want to be? Veterinarian or pediatrician kept showing up on all of my annual, from grade school all the way through high school of what you want to do with your life. And being a technician, I was fortunate enough that I started working at a practice when I was in undergrad. And when I started working at that practice, I literally started out as Saturday morning reception. And I was cleaning kennels, I was doing anything I could, and just gradually started getting more and more hands-on to the point where I gained so much experience as a technician that I was a full-time technician. And I have to say, being on that side of things, that the true caregiving part of things helped me a lot. But it also helped me when I went to the other side, when I'm a veterinarian and I'm trying to get, I'm overseeing technicians to get a busy clinical practice and get through the day and understanding where they're coming from and where their experiences are. And even, I look at receptionists even as the toughest job in the hospital is reception, because they have to deal with everything right up front. They're the face of the practice. And whether it's an upset client over a loss or whether it's an angry client over a bill, they're the one, or they can't get in today. It's always that kind of thing that they have to be the front. So I think our support staff and being part of that support staff really helped me shape my future.
No, I think that's all very true. And I think that's great. I think it's something as veterinarians, it's always really important to remember the staff, right? Like I remember especially as an intern, I leaned pretty heavily on some of those seasoned technicians to help me on some of those overnight shifts and things. And I think that's great that you had that experience and certainly would bring a really different insight, going through practice. And like you said, trying to manage and remembering it from their shoes.
And one thing that was kind of a little bit difficult for me becoming a veterinarian and not a technician was leaving that actual caregiving, where instead of being hands-on and giving the caregiving, which we all enjoy so much, we were the decision maker or the one writing the orders. And the other thing to remember that I often tell veterinarians that we're technicians, I'm like, look, not that you can't put in an IV catheter, but let your staff use their skills, and I find the biggest thing that I push new veterinarians when I meet them and see them, and even new oncologists and new specialists in other practices, I'm like, use your technical staff to their capabilities, because they get bored too. You know, they're going to get bored if all they're doing is holding a dog, and yet they have the talent to not only set catheters, but also to do some procedures depending on what state they're licensed in.
Yeah, that's true. And the licensing, it is interesting how all that's kind of changing what you can do and things. But yeah, I think it's really important to use your staff, you know, not just for their boredom, but also for your efficiency.
Yeah.
There's no point in the doctor placing catheters, right?
Yeah, I used to tell my doctors, if you're placed, not that you can't do a catheter, not that you can't clean a cage now and then, which we all pitch in and do teamwork, but gosh, you're a really expensive technician when I need you seeing patients, you know, especially when we're so busy. And the only way to use things efficiently is for everybody to do the job they're most trained to, you know. And you mentioned just a brief thing, and I don't want to get off on a big tangent, but you know, one of the people ask me all the time, do we have a shortage of veterinarians? I'm like, well, let's first work on, you know, everyone wants to talk about a middle stage, like a physician's assistant for veterinarians. And I think it's not a bad idea, but I think first let's use our technicians to their capacity, and let's give them, if they're licensed and trained, let's give them that capacity to do those things, because I find there's so many things we still do as veterinarians, especially in primary care practices, that if we have a really talented, well-educated and trained technician, they could do that.
Right. You know, you bring up a really good point, and it is kind of a hot new topic that's going on out there. And I was shocked when I realized how much debate there truly is over, is there actually a veterinary shortage? I thought there was, but then when I started diving into it, it's like, oh, maybe there's not. I don't know.
Yeah, yeah. The two things I laugh about, I'm like, but is there a veterinary shortage? I think there's certainly areas, like they talk about rural practices and such, but I think the truth is I think we're just not using ourselves efficiently, ourselves as well as our staff and all of our support, you know, staff that we have around. So I think there's a lot of things, and we're just evolving, you know, we're evolving just like other professions have. And I think as we've gotten more and more specialized, and surely we have, I mean, you know, the numbers going into specialty practice now, that I think primary care, for a while, people are like, well, if I don't do specialty, I'm going to be bored in primary care. Let me tell you, you're not going to be bored in primary care, especially if you do it efficiently.
Yeah, all the stuff just coming at you, trying to get a diagnosis. It's a whole different realm versus in specialty. Generally, it comes in with the diagnosis or pretty high suspicion.
I'm always amazed when friends of mine ask me a question like, so what vaccine should I give my dog? I'm like, let me call my friend. Because it's like I, you know, it's even when we talk about parasiticides, and I think about how far they've come. I mean, I was from the era where we gave daily Falera bits to our dogs for heartworm disease, you know, and now it's just, you know, there's monthly, and now you're looking at even some companies have out 12-month injectable in some countries for fleas and ticks. You know, it's come a long way, and you know, I was a technician when Hills first came out, and I was a Hills technical nutrition consultant. I did their whole program, and that was amazing at the time. But certainly, yeah, general practice has just exploded. You know, I love primary care for that reason. In fact, well, when I started as a technician, I was in a mixed animal practice. So I, you know, we would be palpating cows on the weekend, and in the afternoon doing, you know, spays and neuters and dentals in the morning. In the afternoon, we'd be doing lameness exams or colic exams on horses, you know. So I thought for sure that's what I'd end up doing. And then I got this specialized.
That is a lot of variety for sure. See, I've seen all those things. And, you know, what did make you decide to go into oncology from general practice?
As bad luck would have it, my first dog I ever had on my own outside of my family, she was a 7-year-old Labrador Golden Retriever mix, and she got a nasal tumor. And of course, it started with epistaxis, and it was through the process of diagnosing her when I was a freshman at Colorado State University that I got to know several people in oncology, several of the residents and such. And it just, I think it was one of those things that it was just like immediately cancer became a friend and a foe. And by friend, I mean, it was just so fascinating to me how the body can somehow a cell can suddenly turn itself back on to dividing, and what we could learn from that. And at the same time, it was such a foe because, you know, everybody just loathes cancer, right? And so it was such a challenge. And it just provided that I was thinking emergency critical care medicine at the same time, when I was in vet school. And what a contrast, emergency critical care and oncology, and part of it was I knew that when I went into oncology, I was helping people every day. And when we got to the point of euthanasia, it usually was more than anything, it was the dog had cancer, the cat had cancer. And yet I knew that I'd help those people, whether it was 1 minute or 24 hours or even 2, 3, 4 years. I knew that I'd been on a journey with those people, where emergency medicine to me was more just immediate feedback, So either fix it and it gets better or it doesn't.
Yeah, emergency is very different. I always tell students, especially, because sometimes if they've done much emergency, they have kind of a bad taste in their mouth about oncology because that's when you see it at its worst.
It's, you think of things like hemoabdomens, it's make a decision now or not, you're going to have to go forward. And it's even some of the other ones that come in with things like hypercalcemia and such that are all emergencies. And they're the extreme badness of cancer, so.
Yes, for sure. And it sounds like you really like clinical practice. So what was it that made you shift into industry?
Yeah, I'm going to blame my mentor, Mary Kay Klein, which many people out there know. And we were always doing clinical trials when I was a radiation resident with her. And what I liked about the clinical trials is not only were you on the cutting edge of science and you were working with other oncologists, truly other researchers at whether it be at University of Wisconsin at the time or Colorado, but you were always working with other people that were interested in the science. And you were helping your patients. So I really got involved in clinical trials. And along with that, I started realizing that the pharmaceutical industry is a whole nother side to things in vet medicine. And it really is. It's a different world. And it's a really important world, especially in oncology, if we use it correctly and use it for the benefit of our patient. And that's what I strive to do early on in my clinical career. And I started serving on scientific advisory boards. And that's really where my interest became kind of switched on to, wow, what can I do on the other side? Where can I take my benefit? Leaving clinical practice was tough for me. In fact, I had clients that I'd known 10, 12 years that were saying to me, oh, you're going to miss this so much. And, early on, and I would tell this to anybody that's thinking about industry, do what I did, keep your foot in the door. And I did. I negotiated my first contract and I said, I want to work 2 to 4 days a month in clinical practice. And we agreed on 4 days a month. So basically 1 day a week equivalent, where if I wanted to, I could locum in clinical practice. And that kept my foot in the door. But what was also good about that is early in my career, I was able to use the drugs that I was talking about. So when I was talking about a product, I could say, yep. And in fact, I've used this in my patients. And so it really helped from that aspect as well. I quickly realized that as much as I loved clinics, I either had to be all in or all out for me, because it was hard for me to do 1 day a week or even 2 days in a row and then not be back for 2 weeks. And that was hard for me not to have the follow-up. As my career went further forward, I realized that I was much better off helping the greater good, is what I call it, teaching other veterinarians as much as I can, or bringing more science to oncology or for that matter, anywhere in the veterinary science world.
Yeah, and I would say you definitely brought a lot with QBiotics. You guys have done a ton of education work with Stelfonta, which we'll talk about. But what is it like? Can you talk to us a little bit about your role as a Chief Veterinary Officer?
I have to say, I was fortunate that my first role in industry, my first big role, was with Aratana Therapeutics. And many of you know them from the monoclonal antibodies and for B-cell and T-cell lymphoma. But as well, they came out with things like Entice and Galliprant and Nocita now, which are products of Elanco. And what was fortunate about Aratana is it was such a small company that I got to see all aspects. So I wasn't just a veterinarian in the field teaching veterinarians. I was also working with the marketing team, and I was working with pharmacovigilance, and I was working with even the business development team and even the R&D part of Aratana. And so it was great to see so many facets of pharmaceutical. And that kind of gave me the insight to know, what am I really interested in, right? And because there's so much we say pharmaceutical, and what I do is a very tiny part of pharmaceutical, but I realized very quickly that what I like is working in the translational medicine. And I kind of knew that when I was even early in my career. what I do in my role at QBiotics is I'm a liaison, and that's really what I am. I'm a liaison between external partners such as Verbac with Stelfonta, and a liaison with people seeking either partnership with us or, as far as external. But I'm also a big internal liaison, and I oversee the vet team, but I talk to the translational team, and I talk to the researchers at Queensland Institute for Medical Research, and I talk to our human clinical team. And basically, my job is to make sure everybody's questions are getting answered however we can get them answered, and it's to say, wait a minute, maybe the vet team can do that clinical trial and get that answered quicker for you. Everybody gets help, everybody gets assistance essentially, and everybody gets to work together. What I find with a lot of companies, and it's very true, whether it's a big pharmaceutical company or a small one, I found that many times people get literally siloed into their little groups. Like R&D works totally separate from marketing, works totally separate from business development, and totally separate from another group. And the truth is they can learn so much from each other. And a simple example is, say, R&D comes to you and says, hey, we got this great product, blah, blah, blah. It's going to stifle cranial cruciate injuries in one fell swoop. It'll be a 10-minute procedure, but it's going to cost $12,000. And I can go to marketing or business development and say, guys, this is awesome science, but what do you think? And they may go, no way, you'll get 3 patients a year that'll use it, because the cost is too high. So, or it's too hard to produce, when we go to production or manufacturing, they'll say, no, it's a great idea, but it'll cost us twice as much to make that product. So it's a really interesting way to get everybody's needs met.
Sounds like throughout your career, you've kind of had a niche where you've been able to kind of learn from everybody, right? Like as a veterinary technician and see everything, and then in the clinics, give you a broader view. And then even in pharmaceutical work with smaller companies, and now kind of have that insight of, yeah, they all need to talk because like you just said, something that may sound great, the reality of it may not be so great, right? So It's so important that everyone talks. So that's really fascinating.
Yeah, it's really helped me develop, I guess, my leadership style too, because I really believe everything is done better in a team atmosphere, learning from each other. And I think the same thing happens whether it's at a clinical level. I think so often a technician that has maybe 15 years of technical experience can come in and, new to a practice and say, oh, well, I don't want to say we used to do it this way, but what do you think about this? And have suggestions. And I think it's to suggestions from everybody. And I think same within pharmaceutical, it's worth listening to suggestions from everybody in the group, because everybody looks at things at such different angles. And the biggest thing is that I know for sure is so often I am not the smartest person in the room, and there's other people that are so much smarter in so many different ways. And it's more a matter of recognizing what each individual brings to the benefit to the table. No matter what team you're in, you find you all have the same goal in the end.
It's kind of that recognizing everybody else's skills, like you said, like you don't have to be the smartest person in the room, but how can we all work together, how to tease all that out? So that's great. For anyone that's interested in going into industry, any listeners, if we have any veterinarians that are listening and thinking about that, what advice do you have for them?
Yeah. So my number one advice to everybody is network. It really is. It's the beginning of everything. And from a specialist, if you're interested at all and somebody says, hey, you want to be on an advisory board, say yes. I mean, most of the time it's not a huge commitment, and you'll find out right away whether it's interesting or not. On those advisory boards, you meet lots of colleagues. If someone asks you to serve on a discussion panel, it may seem odd, but some of the people I know the best, I met on discussion panels for like advising residents on what you would advise them to think about in their first year and their last year. Even if you're in primary care practice, the greatest thing about being a veterinarian is you can be doing something today and you can say, I want to try that instead, and you can try. And you always have your skill set to fall back on. And I don't mean to define you only as a clinical veterinarian, because I think that's the problem with veterinarians is we find that it completely defines us, who we are. And we're so much more. If somebody asks me, what do you do? I'd love to tell them, oh, well, I volunteer every year in Africa and I vaccinate dogs for rabies. And it's the greatest thing I do in my life. But I also like to go hiking and I travel a lot. I don't want to tell them, I'm a veterinary oncologist or I'm a veterinary consultant. I'd much rather tell them about all the other things that make me who I am. And I think veterinarians forget that there is so much more to them. And the other thing that veterinarians is, you think all you know is clinical practice. And I will tell you, if you can do clinical practice, you have become efficient at managing teams. You've become efficient at time management, at scheduling. You become efficient at multiple. I mean, there's so many things that come with clinical practice that you don't even realize have given you a skill set that you can take anywhere. And you can even take it into sales, believe it or not, because veterinarians don't want to say they're salespeople, but we are. We're salespeople, but we really believe in what we do. And so it's not hard for us to be salespeople, because when we're giving a recommendation, whether it be for oncology or whether it be for treatment of Addison's disease, we really believe in the medicine behind it and what we're doing.
Oh, there's so many good nuggets in there. You probably have one of the best elevator pitches I've ever heard, right? Like, instead of just saying, oh, I'm a veterinarian, it's like, no, I go to Africa.
Yeah.
I love it. You need to pick things that you enjoy and really highlight that, and not just a one word. That is great. I love that.
Yeah, Rachel, you're so right. And it's just become something that in the last, and I think transitioning into industry really made me see that, because I was at a point where I was like, oh, I'm a great oncologist. I'm brilliant at this. I've done this so long. It's just like second nature to me. And it's like, wait a minute, but are you enjoying it as much as you did 15 years ago? Are you enjoying your day to day? And are you giving back what you think you can give back? Or are you putting in what you think you can put in? And I think at the end of the day, one of the passions for me is, gosh, you don't feel like you're stuck in vet medicine, because I love being stuck in vet medicine because you can do so much. Veterinarian is just to me, it's a stepping stone to so many places.
So true. Yes, I love that. And I think you bring up a lot of good points to help people battle burnout, right? Like, if you can focus on not, like, what else do you like? What else? And trying to improve. Because I feel like for so many of us, you have to be very goal oriented to get through vet school. For myself, I kind of struggled. It was like, once you hit those goals, it was like, well, now what? What is my goal now? So I like what you're saying about really investing in the future, thinking about other things like, okay, what are maybe not as tangible in the sense of like, okay, I have this degree, but what, keep having goals, keep pushing yourself.
And you're exactly right, because I said, and that's the way, when I finished my second residency in radiation and I passed boards, I was like, so this is it? Wow. I've been working my whole life for this. And it wasn't that it wasn't great. It was great, but I was like, now what? And it really was that big now what, like you describe. And it was like, wow, well, I didn't have anything else on the list. so you're like, well, what are the lists? And for some people, it's, for me, initially it was, I want to do a triathlon by the time I'm 40. And I did, and that's what it may be. I just want to run a half marathon, or I want to do a marathon, or it could be doing like I do. I volunteer every year. That's kind of my reset point. It could be, I want to climb every 14er in Colorado. It could be, there's so many things you can do out there in the world. You just have to find what you enjoy. Again, off on a little tangent, but one of the things I did this year is I have spent the better part of my life reading nonfiction. And last year I said, I'm going to start reading fiction books again. And I started checking fiction books off my list. I started with classics, of course, because what else do? You look for the best 100 list. And I couldn't believe how different it made me think. My CEO actually encouraged me to do it. I took a drawing class, and now I sketch all the time. So I'm doing pencil sketches. And who'd have thought that I'd be drawing at this time in my life?
Yeah, that's really cool. I like that. I used to read more fiction, and now I've kind of shifted a different stage of my life. Now I'm reading all nonfiction, but I also agree with you on the classics, because I feel like they're a classic for a reason. What's been your favorite that you've read most recently?
So one of my favorites, believe it or not, was Handmaid's Tale again. I mean, that was one of those that it's like, do I really want to read it again? It's always been one of my favorites, but you look at it differently now that they've made series and other things out of it. The list is just unreal. Like, I couldn't believe, I've read a couple more of Nathaniel Hawthorne's. I just started pulling stuff off the list, and it's amazing. Some of them came off of blogs that I listened to, and I was like, oh, she mentioned that book. Maybe I'll read that. And it's something I never would have picked up as far as fiction. And I just said, okay, well, get into the style and see what the author's trying to say. Look at it for art's sake type thing.
I applaud you for making it through a Hawthorne.
It's a whole different, well, gosh, you want to use music, pentameter, it's just a whole different, wait a minute. Okay, let's try reading that page again.
Definitely a whole different style back then. I feel like before TV, they wrote much more flowery because people had a lot more patience and more time.
Yeah. The one thing I had to learn from a friend of mine, she reads fiction like, she reads a book a week type thing. And she said, oh, Pam, are you really reading these word for word? And I'm like, well, yeah, aren't you supposed to? She goes, well, maybe some of the classics, but really what you need to do is like more skim the paragraph and get the idea. And I was like, now I get why you read so many books.
Well, that's awesome. I love how you're trying different things. And I think that's, great advice just for all facets of life, of trying different things. And then I do want to circle back to more towards clinics to kind of, hear a little bit more about what you think was Stelfonta. I mean, we've talked about it. I use it. I think it's a great therapy, but it is very different. So I guess kind of maybe just a real brief, because probably most people listening to this know what Stelfonta is, but maybe just real brief what it is. And when do you think it's a good time to use that type of therapy?
Yeah, it's a tough drug because it's so innovative, and it's the first time that a drug has been approved for intratumoral injection. So for those, just briefly, it's approved for intratumoral treatment of mast cell tumors, and specifically cutaneous ones anywhere on the body of the dog, and subcutaneous below the elbow and hock only. And what's interesting about it, it has a really complicated mode of action. I laugh because what we know about mode of action, I work with the researchers at QIMR, and I kind of look at them and go, so there's more to this story? Because there always is with these molecules. And so it does cause local oncosis. It also causes an innate immune response locally and inflammation, and it basically causes the tumor vasculature to become leaky, and overall it causes necrosis. What I think is more interesting about the drug than all that is the fact that it has wound healing properties, which that just surprised me, what it does after the fact. The hard thing about a drug like Stelfonta, because it is so innovative, is, and I've seen this for 25 years, is the minute oncologists, and Rachel, you better agree with me, the minute oncologists get a new drug, they go, oh, well, I got nothing else, I'm going to throw that new drug at it. Right. And we all did it with Palladia. Oh my gosh. I put more dogs on Palladia with more diseases in the first year. And it was just, I got nothing else, give it Palladia. Well, the difference between a drug that's oral like Palladia that causes GI signs as its primary side effect, you have a drug like Stelfonta that you're injecting in the tumor and that actually works locally, because I will tell you, I injected a lot of carboplatin, a lot of bleomycin, a lot of you name it into tumors and saw nothing happen. And the first time I injected this, I went, whoa, something happened. Now I have no tumor, but I have a big hole. And I think that's the biggest thing you have to realize is no matter what drug you use, you have to set realistic expectations. The downfall is I see it done with even new drugs like Laverdia, another new drug. And people go, oh, well, I tried it, but it didn't work. And it's like, yeah, but you tried it on a pet and a patient where nothing's going to work, right? I mean, sometimes I get calls about cases for Stelfonta that I wouldn't touch them with radiation, chemo, or anything. I just basically talk to the owners about a realistic, quality of life talk and say, look, guys, I know you're looking for a home run here, but this is not it. It's probably the only drug that I've used in oncology where I say, follow the label, really stay within the guidelines of the label, because pushing it outside of the label doesn't work. And I'm the first one to know that. Have I rounded up doses of chemotherapy once I got comfortable with things like carboplatin? Sure. If it was 305, I'd say give 310 or, whatever, but it's not like that. This is really seriously something you need to stay within the bounds of the label, at least until you get very comfortable with it. Once you get comfortable with it and you understand how it works, then I think there's always room, if you're comfortable as a specialist or whatever, using it in some other manner. But definitely the label is there for a reason. And it's meant to be followed, because we found in the first 3 years that, because it's been out more than 3 years now, we found that most of the things that get reported in pharmacovigilance, people have used it off label, whether they didn't use the concomitant medications or they treated a tumor that was 2 times above the label restrictions, or used it on a big tumor on a little dog, which was going to make that little dog really sick. And so, yeah, that's my biggest advice, is use it within reason and realistic expectations.
And I always tell people too, to really check out the website. I think you guys have done a good job between Verbac and Stelfonta. You can really, double check your dose. There's the math equation. So for me, it's like, why do the math by hand? I mean, you can, but double check it.
I still use the website to check my doses. I calculate them by hand. And if I get an email from somebody asking me, I'll double check the dose and then I'll put it in the calculator, because it's such a unique way of calculating. Like, the first thing I had so many oncologists ask me, why is it length, width, height times 1/2? And I'm like, well, let me explain. Length times width times height is a square or a rectangle. And if you hadn't thought about that, because we write it in our records all the time, but we haven't had a drug where you needed to know the actual volume, which is modified ellipsoid is your best one, which is the multiplied times half. I definitely say, I agree, use the website. When you're educating clients, use the website. There's pictures there for a reason. We want clients to know. And, I embrace the wound for Stelfonta like I do radiation burns, because I've been educating clients for 25 years on radiation side effects and what they're going to look like. And back in the day, I still have it, actually. It's probably worth something now. I have a photo album of radiation side effects that I made when I was a resident. So this is in 2002. I made this photo album, one for MK's practice in Tucson, one for our practice in Phoenix. I made like 3 or 4 of them. And literally, it has the worst of the worst pictures. Well, now we have digital, so we can show you on our phone and we can show you on computer screen, and it's worth it. And what I found is, much like radiation, is if the client is prepared for the side effects, they're not as shocked. And in fact, I've had clients walk in and tell me with radiation burns, it's not as bad as you said. Did you give enough dose? And I'm like, I can assure you, I gave the highest dose possible. And Stelfonta, the owner feedback we get is usually, oh my God, when they're educated, of course, oh my gosh, it totally ripped that cancer apart and killed it, and now it's healing. This is awesome, And it's interesting that it's a matter of education. And it is a visual, as my Australian friends will say, it's confronting. They use the term confronting. I'm like, confronting? It's downright disturbing if you're not ready for it, So, but it's a wound, and we're not used to creating wounds, overall, unless you're a radiation oncologist. Sometimes we do.
Right. No, I do. I agree. I feel like this is definitely a drug where you need good client education, because if there's someone that can't handle blood, this isn't a go. And the wound aspect that you mentioned earlier about how this works with wounds, and I agree, it is fascinating, because I remember hyperthermia and some of these other therapies that would fry these tumors, but then you were left with these huge holes where a real wound, versus Stelfonta. It is kind of crazy because you get a wound, but it heals up. Like, we don't have to do the bandaging and the flushing. It's not like a burn, like if a dog like comes in on the ER. So you want to explain that a little bit more?
Yeah, so some of the healing properties the drug has is it does cause keratinocyte migration. It causes something called netosis, which netosis is basically the neutrophils form this net or webbing, and it blocks biofilm. It disrupts the biofilm that bacteria form. And so and it also causes the fibroblasts. It basically causes maturation of the fibroblasts and such. And so through that process, it enhances healing, and it also decreases the risk of wound infections. I think the biggest thing is people always say to me, well, you don't need to bandage or don't need an e-collar. And I'm like, within reason, because I'm not saying no dogs ever need an e-collar, because you have dogs that will traumatize the wound because they won't leave it alone. But for the most part, you don't need those things, and you don't need to manage the wounds. And I think that's a great benefit of Stelfonta. And what we've discovered is it's part of that epoxy-tigolane class that it's in. We have another drug that we're going into human trials, a wound healing drug that is actually makes Stelfonta's wound healing properties look kind of mild compared to what it does. So that class of drugs alone is just really beneficial in that aspect.
That's interesting. Yeah. What other are you guys looking at other uses for Stelfonta? I mean, other than mast cell tumors?
Yeah, it's a good question. And one of the things that we've learned about the drug in and of itself, and this is both in early pilot trials in dogs as well as pilot trials in humans. The first phase 1 trial we did in humans was head and neck, and it had squamous cell carcinoma, it had some adenocarcinomas, it had basal cells and melanomas. And we found that it was a broad range that actually responded, which was interesting. And a lot of that is it's what you would call a tumor agnostic. It doesn't target directly the tumor, it targets the tumor vasculature and stimulates the immune response and such. Specifically in dogs, we have done several phase trials in soft tissue sarcoma. And in fact, we are finishing a trial in soft tissue sarcoma in dogs right now. Suffice it to say, it's used very similarly, but different con meds and also a little bit different dosage structure. But we found that it works in that as well. And then again, in pilot trials, we found that it works in a number of different tumors. In fact, I think when we talk on the human business development side, we've now had it in 12 different species in many tumor types. I can't even remember the number of tumor types. And of course, some of those are just N of 1, but we're seeing responses. As far as the human side, which if you've gone to the QBiotics website, you know that we've done more than just the phase 1 in the head and neck, and we've actually closed trials in melanoma in humans. And right now we have 2 active trials, one in head and neck solid tumors. It's a phase 2 trial and a phase 2 in soft tissue sarcoma. And the soft tissue sarcoma, I think, is nearing closure. It only took 6 months to enroll that in the human in the clinical trial that's here. And that one's one that we're doing with Memorial Sloan Kettering.
That's really exciting. Well, that is great to
Yeah.
see. And I always love things where, we can learn so much about it in our pets. And then that's a drug we now have or a test even to help with our pets that then moves on to help people. I love that. That's one of the reasons
Yeah.
I got into oncology. So I love that you guys are being able to do that with your products. And, one other thing I had a quick question for you is, veterinarians, we love to use things off label. I know you said to follow the label with Stelfonta, but you guys have found it works with other tumors. What would you say to vets who want to use this in something other than mast cell tumor? Would you say yes or no?
Well, I'm going to have to inform you that it's off label because I work for the company. So I have to tell you that. What I would say is if you're considering using it for tumors that are not mast cell tumors, don't hesitate to reach out to me or reach out to someone from Verbac that can give me a call, reach me if you don't know my number, don't know how to reach me. Because many of the tumors I can give you hints on, or I can tell you what we've experienced. Of course, warning you that it is off-label use of the drug, but I think for the select patient, it definitely is suitable. And again, we mentioned soft tissue sarcoma. That's probably the one I get most commonly from oncologists is soft tissue sarcoma. And certainly there are limitations, much like limitations on tumor volume, much like there's limitations on mast cell tumor volume. And that's through experience we did a trial in Europe, and like I said, we're finishing another prospective trial now.
How exciting. When do you think it like maybe within the year or two, we might have those like the data on that published, do you think?
Yeah, that should be within the year because we'll be closing that trial easily this quarter of this year. And certainly, I think we're at a point where efficacy data and early safety data will be available. Yeah.
Oh, great. Talking about QBiotics and what you guys have, is there anything else you've seen kind of coming down the pipeline for just oncology or veterinary medicine that you think is really interesting?
Yeah, so most of the stuff we're working on is not oncology related right now. I mentioned the wound healing product, and that may be something we're exploring the possibility of vet medicine for that too. And then we have a few other that are early anti-inflammatories and antibiotic type products that were in early work. Too early to really say when that would be on the market, but early enough to say that we're actually dabbling in that right now. Yeah.
Well, great. Well, we'll certainly have to keep an eye on you guys. As we're wrapping stuff up here, one quick question. Who else would you recommend to do this podcast?
Well, and he's going to hate me for always recommending him, but Chad Johannes is someone that I recommend if you have not had him on, and I don't think you have. And the reason I recommend him is, believe it or not, Chad and I met at Colorado State. He was a first-year intern and I was a senior student. It was my first week on clinics. I think at that time we called it clinical practice or something. It's basically, it was triage. It was receiving on clinics. And I got to know him that first week of my senior year, and we've both followed very similar paths in that we worked in industry. He is in academia now, although he had a very strong time period in industry. And I think there's a lot to learn from him, because what he's done in academia is very different than what he did in industry, and is very different than what I do. But it's still an important area that people can look into, whether it be being medical director or hospital directors, that kind of thing.
Yeah, no, Chad would be great. You're right. He would certainly be a great one to have on this show. Well, Dr. Jones, I thank you so much for being on this podcast. Learned so many great things about just teamwork and seeing different aspects of the veterinary field, and certainly learning more about Stelfonta and different products and things you guys have coming out. So thank you so much. And where can people reach out to you or find you? What would you recommend people? Where should they look?
Yeah, so probably the best thing is QBiotics. You can always send something to the general, but my email is really simple. It's pamela.jones@qbiotics.com. So it's very easy. You just have to remember the dot between Pamela and Jones.
Nice. Well, thank you so much for sharing. I know people always have a lot of questions about Stelfonta, and still learning as we go along with that. And again, thank you so much for being on this podcast. I really enjoyed it. Thank you so much.
Thank you, Rachel, for your time, and thanks for asking. I enjoyed it.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Infomed.